This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to MyHeart.net podcast. And today we thought we would talk about chronic venous disease, mostly to increase awareness about the problem that we have. Chronic venous disease is often overlooked by healthcare providers because of an underappreciation of the magnitude and the impact of the problem, as well as incomplete recognition of the various presenting manifestation of primary and secondary venous disorders. The importance of chronic venous disease is related to the number of persons afflicted and their socioeconomic impact for its more severe manifestation, like venous ulcers. So chronic venous disease is a very common problem, and with varicose veins affect more than 25 million adults in the US and more than 6 million people with more advanced venous disease. So, today we were going to discuss this very important topic, and we invited a specialist in the field, Dr. Robert Foster, who's director of the Birmingham Heart Clinic at the Vein Center. And Bobby is a cardiologist that I've known for over 30 years. So, Bob, thank you very much for agreeing to do this with us, and welcome to MyHeart.net.
Thank you, Dr. Bouchard. I really appreciate the opportunity.
That'd be great. It's great to get back together like this. So, Bobby, if you could maybe explain to us a little bit about what is the normal venous anatomy? How does it function? How do we bring the blood back from, the lower extremity all the way back to the heart?
Absolutely. So, it's a very complex system because initially most of my work was in arterial disease. And it's basically you have these multiple tubes coming out of the heart as arteries, and they go straight down to the foot. But then it's a little bit different in the venous system because it's a low pressure system. So basically that pressure, that low pressure blood has to work its way from your feet all the way back up to your heart again to be pumped out again. And there's multiple levels. It's not just one set of tubes like there is in the arteries that just go down and begin to divide. There are multiple levels. So you've got the deep veins. The deep veins are the largest veins. They actually run in the muscles. So they actually have, to some degree, a pumping mechanism. When you walk or you pump your calf, they'll pump that blood back up. But then you have a secondary system that's called the superficial system. And that superficial system runs parallel to that. Typically goes up the leg parallel to the deep system, then dumps into the deep system predominantly right about the groin level. Now, there are also multiple connections between these two systems, which we call perforators. Those also have these specialized valves in them. We'll be talking a lot today about the valves of the veins. But that's the way the blood that inches its way up. And it has to get up. Well, you've got another set, which if these become abnormal, it pushes that blood into a more superficial system, which are the varicose veins that you actually see. And then you can have another system that's even in the dermis, which is the small spider veins. So you have multiple levels all communicating with each other that allow that blood to go from your feet all the way back up to your heart. And when that becomes abnormal, you start seeing a lot of the manifestations of that, not only visible, but also clinical. And we'll talk about some of the clinical manifestations of that a little bit later.
So you're standing, you have some blood in your veins, and it has to go all the way up, to your heart. You're in the superficial venous system that drains into the deep venous system. And those valves, this is what's very instrumental in getting this blood back up. I mean, because you have to go up like 100 millimeters of mercury, and it's not that easy to conceive.
Exactly. That's a long tube of blood going from your heart all the way down to your feet, which is under an enormous amount of pressure if it was a completely open column. But what happens is, and the way the body protects the ankles and the legs from that, is a series of valves. And those valves are like steps of a ladder. So basically the blood goes from ladder step to ladder step. And if those valves start to separate because the veins become engorged, then you have this column that basically begins to fail. So you have more pressure on the next rung and the next rung and the next rung. So it basically perpetuates itself. So what we do is we can actually measure how long is blood flow going backwards through those valves? And we call that regurgitation. And so that's what actually the disease is in venous insufficiency, is it's that leaking of those valves. It just leaks that blood all the way back. So your ankles are no longer protected from that really high pressure. And it can be almost at the arterial level. So if you have completely open veins, completely open valves in that superficial system, the pressure in the legs can be almost 100 millimeters of mercury. It's very, very high.
So this is the main problem about, what happens with the pathology of the veins. I mean, you have these valves that become ineffective, and therefore you have blood kind of sitting in the legs. What is the problem with these valves? I mean, how do they become, inefficient or damaged, so that they don't work anymore?
Yeah. So the main thing, I guess, number one would be genetics. So that it is a genetic abnormality. So that if your mother has it, it's about a 70% chance you'll get venous insufficiency. If your dad has it, it's about 90% chance. And if they both have it, you're going to get venous insufficiency. So if you have a very strong family history, so you look at your parents' legs and they have these terrible looking legs with large varicose veins or discoloration on the bottom part of your legs, start at a young age and protecting those. And we'll talk about how to protect them. But start very early. So genetics is the first one. Second is occupation. So if you're standing a lot in one place, so we see this in hairdressers, people who are, in nurses and physicians and people who are standing at counters for prolonged periods of time on hard floors. Those are the patients that are going to get it. Because basically what you're doing is you're exposing your legs to that high pressure without creating a pump. So while you're not walking. And so that basically puts too much pressure on the system, and then they start to enlarge. And as they start to enlarge, those valves just pull away from each other. So that's the next thing is really is occupational. And the third is we see very high pressures in people who are sitting without their legs up. So we see a lot in truck drivers and patients who travel a lot. Those are the patients who are going to get this disease most commonly. And then patients who have a deep vein problem, like if they've had previous clots in their legs, their valves are going to begin to fail because you have an obstruction up top.
I guess you have also patients that've had women, with multiple pregnancies, maybe who've had tendency to have maybe varicosities, as well as maybe patients with that are overweight or obesity, and also, a lot of times sedentary, just have more problem with, venous insufficiency. So we're talking about venous insufficiency. You're talking about the increase in the pressure in the legs. So we've had so many segments on hypertension, and now we're talking about this chronic problem of venous hypertension. How does it manifest itself, clinically? What do you see? What do patients feel? What do they complain about the most?
Yeah, probably the most common complaint that we hear is patients who have this aching and heaviness in their legs at the end of the day. We see a lot of restless leg, where basically when patients go to bed, their legs have been exposed to that high pressure for a long period of time, so they start to move at night to try to find a comfortable position. Night cramps are very common, and so we see that as well. And then we also see some swelling. So if people have swelling at the end of the day. Now, in more advanced stages, we start seeing not only the varicose veins, but we also see discoloration of the skin. And what that is, that's basically that under that very high pressure, the body doesn't want the legs to get really big. So what it does is it actually starts to damage the skin to create more tension in the skin to create its own compression sock, if you will. And by doing that, it lays down iron. So that iron hemosiderin, you've probably seen people who on the bottom of the legs, they start turning brown or black. And then ultimately that skin can actually break down and you can get ulceration.
So those kind of skin changes, I guess you get a lot of inflammation at the level of the skin or even at the level of the veins that really kind of introduce this skin problem where there's really, poor nutrients, getting to the skin. And that's why you have a breakdown of the skin, isn't it?
It really is. And it's very hard to fight infection, so people can get cellulitis. Interestingly, though, we have other manifestations of it besides that. One of the most common things that we see is itching. So if you see patients have itching, patients can develop eczema on the legs. So you get these kind of white patches on the legs. So those are other common things that we typically see. And it's interesting because it's not always one thing. Some people just get itching. Some people just get swelling. Some people just get night cramps and a restless leg. So the manifestations are very different in different people. So you just kind of have to, as a physician, ask those questions to see, because it can really affect their lifestyle. So it can affect their ability to sleep. It affects their ability to, after they get home after work, to want to go exercise or to want to go walk because their legs are hurting and they've just got to go sit down and kick their legs up.
I've seen some patients also sometimes that describe even symptoms of claudication, having increased pain after walking. How do you explain that from the venous disease standpoint?
Yeah. Well, whenever we get really exertional discomfort, so if you're walking and it hurts and then you stop and it gets better, one of the things we worry about is there an outflow problem? Is blood flow getting down there, but they can't get out? So that during those times when you're pumping more blood down there, and if it can't get out, then that causes kind of an immediate, sudden engorgement of those veins. So whenever we hear venous claudication, we always worry about obstruction. And that's typically obstruction in the deep system, not obstruction in the superficial system.
Now, you have some different ways of classifying, the severity of the venous insufficiency. Can you describe that, some of these components that, for example, that SIP, classification, where you have how do you actually kind of evaluate the patient in the clinic, with their symptoms and I guess also their clinical findings? How do you classify them?
Right. So the SEAT classification can be as complicated as you want it to be because it can go through all the etiology and the physical and clinical manifestations of it and what caused it to begin with. But probably the simplest explanation for that most of the time, that's how we communicate and what level we communicate, is a SEAT classification of a SEAT 1 through 6. So 1 is basically, or 0 is basically no symptoms at all. And no clinical manifestations that you visualize. The SEAP1 is basically where you just have small spider veins or reticular veins. SEAP2 is when you get the larger varicose veins, and those are usually at least 2 to 3 millimeters or larger, and they're right on the surface. So that's a SEAP2. SEAP3 is swelling. So anytime we see swelling, that's a SEAP3. SEAP4 is when you get that discoloration, and that's what we call lipodermatosclerosis. And so whenever you get that darkening, that iron deposition or the eczema, that's typically the SEAP4. Those are skin changes without ulceration. SEAP5 is a healed ulcer, and SEAP6 is an ulcer and is an active ulcer. So the problem with the SEAP classification is that it doesn't really tell you if the patient after your treatment is getting any better, other than they can go from a 6 to a 5. And when somebody is a 5, they're always a 5. So, once they have a healed ulcer, they always have a healed ulcer. So really, especially on those patients, if you want to say, well, they're getting better, that's not the best way to tell. So we do the SEAT classification just to kind of tell where they are in the stage of what they look like. But we also use a VCSS score, which is kind of a clinical classification. It's more complicated. It looks not only at their symptoms, but also what their legs look like visually, and also whether they're wearing compression socks. So that's an easier way for us in the vein center to be able to say, listen, they went from a VCSS of 30, and now they're all the way down to a 6. So it's a broader range and allows us to say that our treatments are working if you want a numerical degree for that.
Yeah, I can see how a severity score would be helpful to evaluate your treatment. So let's say this patient comes to you in the office, or the patient is referred to you. What kind of evaluation do you do with them, Bobby? I mean, what do you find on physical exam, and how do you make a diagnosis that you have someone with venous insufficiency?
Well, first we, take the history, and if the history fits and they have a strong family history, or they've had multiple children, or they have an occupation that supports it, and then they begin to have the symptoms that go along with that, which we described earlier. Then we look at their legs, and on physical exam, if we start seeing the changes on their legs, then the next thing we have to do is to send them for a diagnostic test to see, do they have venous insufficiency? And that's with an ultrasound. And so we do venous duplex on those patients. And the venous duplex will actually not only see at what level they have the reflux but also look at their deep system, make sure they don't have obstruction like a previous clot or reflux of the deep system, and how the shallow system's communicating with the deep system. So you want to look at all the perforator and see if they have perforator reflux. And so we have these ways of provoking reflux to see if the veins are competent. And it's basically by putting the ultrasound probe over the vessel, squeezing the vessel, and see if as we squeeze the vein, if we see blood going through the vein, we actually typically squeeze it below the area we're imaging. We see blood go through the vein, and then we measure how long is it falling backwards. And that should be less than half a second. We measure that in milliseconds typically. So anything over 500 milliseconds in your superficial system, what we call the truncal system, is significantly abnormal.
You do that with the patient standing?
Do it with the patient standing. You don't necessarily have to. You can actually do it with the head of the bed, head of the stretcher just elevated. We can actually just put them into a type of reverse Trendelenburg, so their feet are lower. If we still can't get it with that, then we'll actually stand the patient up and do what's called provoked imaging. And so that allows us to see it a whole lot better. But I'll tell you, it takes a very specialized echo tech to be able to do this. It really needs somebody who does a lot of vascular studies. I think there's a lot of venous insufficiency that's being missed because you don't have qualified techs that really know how to identify it. And so, when we see patients who have, classic changes in their legs, classic history, and then we send them for a reflux study and they don't have it, or they're sent to us with a reflux study without it, then we'll get our techs to repeat that because typically it's there. Clinically, it's there. Likelihood is there. It was just missed on the Doppler study.
Do you use any plethysmography where you pump up these cuffs on the legs, or even other techniques like CT or magnetic resonance imaging, venography, or is there any application for that?
So we typically just do hand pumps. We don't do the plethysmography. And the MRVs and CTVs, if you look in textbook, there are some beautiful images that you can obtain. Typically looking at the deep system. We typically don't do it for the superficial system, but for the deep system, you can get some great imaging. The problem is consistency. And so if we're wanting to look at the deep system, then we in our practice, and people who have other practices may go a different route. If they have really good radiologists that can do that type of imaging, then I say go for it. It's a non-invasive way of doing it. To look at the deep system more consistently, kind of the gold standard is venography, just putting smaller catheters in the femoral veins and injecting. And looking to see if there's any obstruction more proximally, and intravascular ultrasound, where we actually look at the vein from the inside with a small intravascular catheter.
So you try to do that mostly to rule out deep venous obstruction, or like we'll talk maybe a little bit later about post-thrombotic syndrome.
Mm-hmm. Yeah, so I do think that typically the most common thing by far is reflux in the superficial system and not obstructive disease and secondary reflux. So we typically will treat that first unless we have very clear clinical evidence of highly suspicious for an obstruction. And those would be if somebody has, unilateral reflux and their other side looks fine. There's got to be a reason for that. Both legs have typically been exposed to the same thing all their life. So why is it just on one side? Or if they have chronic swelling on one leg, if they have, chronic pain on just one leg, recurrent DVT on just one leg, those kind of things make us very suspicious. It's going to be unilateral obstruction. And that's typically due to a May-Thurner type syndrome that we see.
Sounds great. Well, let's talk about treatment, Bobby. First, there's something, that you do conservatively first in the patient that you see in the office. What is your first approach on these? Yeah,
so the first approach really is education. You got to educate these people that they have venous insufficiency. And because of that, they are going to expose themselves at work. And you can do everything that you can, trying to fix them. But if you don't make them aware of it, that they need to, when they're sitting down, elevate their legs. Gravity is the worst thing for these legs. So when you're sitting, when you can, elevate your leg. And if you're sitting at a desk, even if you can put your leg up a foot off the ground, 12 inches off the ground. It makes a difference in your venous pressures rather than just dangling them straight down. Secondly, is basically helping support those veins. And we do that through compression socks or compression hose. The compression hose there really hasn't been any great data that you have to go above the knee. So you really can't compress the thigh veins enough. It's almost too tight to be comfortable. So most people only go from the knee down. And the pressures really need to be, for daily wear, they need to be around 20 millimeters of mercury pressure. If you go much higher than that, then people won't wear them. It's hard to wear in the Alabama summer anyway, but if any other time, it's hard. Now, if you're in treating patients, then it needs to be a little bit higher pressure. You need to be in the 30, 40 range.
And these are hard to put on. I mean, Bobby, if you try to put on these socks, I mean, it's really difficult.
Elderly patients really struggle. And so, but there are some ways around that. They have zip up kinds. They have different kinds. And I do think the compression sock technology has gotten better, where it's compressing in just specific areas. It's not compressing your feet so much. And so I do think that there are some good compression socks out there, but that's what we do. We typically do that for 3 months. That's our standard. And that's actually for any other type of treatment. If you want to do a more invasive treatment, you have to do 3 months of compressive therapy first, the conservative therapy. So we always do that. We always do that first and instruct them on wearing them during the day. You don't typically have to wear them at night because, you're laying down and gravity's out of the picture. So you don't have to wear them then.
What about exercise?
Yeah, exercise is very good for all things, as you know. I do think that it's phenomenal because I said earlier that keeps your deep system intact because it pumps those deep system. It also increases the turgor, your muscles, so that actually increases the tone of these veins. So I think it's very good. The more exercise that you can get, the better.
Losing weight and also couldn't hurt either. I mean,
absolutely.
I've seen patients that after bariatric surgery, losing 100 pounds. I mean, they got rid of their venous insufficiency problem. What about when you have a wound? Do you actually get wound care involved? I mean, when you have the ulcers, I mean, how do you treat those? How do you do your compression with an ulcer?
It makes it very, very hard. And so, because number one, patients don't want to put compression socks onto these ulcers. Most of them, a lot of the patients have nerve damage, so they're not as painful as a lot of wounds are, because they do have a lot of them will have kind of neuropathy of the skin because it's been damaged and been exposed to that pressure for so long. But you have to, the only way these things are going to work and the only way you're going to heal that wound is a combination of good wound care. And wound care has become a science in and of itself. It's not something that you want to just say, just wash it with soap and put a Band-Aid on it. There's some really, really good therapies for wound care, but the wound's not going to go away until you treat the underlying cause. And we see quite a few people who come to us who have been in doing wound care and, seeing dermatologists for a long time before they even get to us. And they just, just saying it's just not getting better. What can be done? And a lot of it's because the underlying treatment has not been, hasn't been taken care of.
And I've seen also a lot of patients with where their legs really itching a lot. They're swollen. They're putting steroid cream on this, which is probably a bad idea. But, it's just not going to help. It's going to probably just thin your skin, make you more prone to develop an ulcer. You just want to keep your legs, I guess, hydrated or lubricated. Unless you use linolene or some kind of, ointment to keep them moist.
Yeah, you want to use lotions that have a little bit greasier than normal, something like Eucerin cream or Udder Butter or something that has a little bit more oily effect, because when the skin starts cracking, that's when the bacteria get in. And that makes them much more prone to cellulitis. And you can, as you've seen in the hospital, people can get really, really sick with bad cellulitis.
Any role for pharmacology? Do you actually have some patients on blood thinners or medications like pentoxifilin or Trentol? Any role for this in venous disease?
Yeah, so really we don't see that much of the vasodilators in these patients. I do think that skin care, wound care, there is a kind of anti-inflammatory that we give called Vasculera. Vasculera is it's a kind of a medical food, if you will. It's prescription, but it actually helps to reduce the inflammatory response in these veins. And it's been shown clinically to be able to do that and heal some of the, help heal some of the ulcers. It's secondary and it gives you the same amount of anti-inflammatory, kind of those natural flavonoids that you can get, that is equivalent to eating about 10,000 oranges a day. So it's from the orange peels. And so they get these orange peels, and that's where the flavonoids come from. And we know that flavonoids do have an anti-inflammatory effect. And so medicines like Vasculera actually work fairly well on people who have really damaged skin. But to treat their true venous insufficiency, it's really more of a skin treatment than it is a treatment. You've got to go to the source, and you've got to take care of that source of the insufficiency. And so that's kind of the next step after compression.
I've heard also about this horse chestnut seed extract. I mean, just like, is this for real?
Yeah, I do think that there is some data on it. And so some of the insurance companies are requiring us to have the patient not only on compression socks for 3 months, but they have to be on the horse chestnut or Vasculera. And the data is not that strong. I can tell you just anecdotally, as far as treatment and long-term treatment, most of the patients that you put them on those, and their symptoms are still persistent. So you really have to go to the next step. But it's great for if you've already treated everything and they're still symptomatic, then those are the patients I really, really tell they need to be on anything that we can do, because we're out of options.
Right. Well, now we're out of option. Let's talk about interventional management. We've got the sclerotherapy. We've got endovenous ablation. Can you talk about that a little bit?
Yeah. So it's kind of odd, for so many years, I was in the opening the vessel realm, and still do a lot of going from a closed to open vessel. And you've got to reverse your mind to say, now we're going from an open vessel that's not working to a closed vessel. And so, it's just a different treatment. But you got to realize these vessels are diseased. They are not protecting your ankles from that pressure. So you need to close them down. Now, we don't close down the deep system. The deep system is a very important system that we have to maintain open. That's the majority of the blood that comes out of the leg goes through our deep system. These shallow systems, they can pool blood and they can store blood, and they can be under an enormous amount of pressure, but they're really not needed if they're diseased. So what we do is we actually close those vessels down, and we'll tell you some of the ways that we close those down. Now, what immediately pops in a lot of people's head is, well, what if I need open heart surgery and I need those veins? Those actually are the veins that you use for open heart surgery. So what, if you talk to most of the CV surgeons, what they'll say is, I wouldn't want that diseased vein going to my heart artery. That's a vital vessel. And so they don't last as long. They're typically varicose, they're enlarged, they're aneurysmal. And so you take a big vein that's diseased and you tie it to a little 3 millimeter artery, and it's not going to be patent for very long anyway. So it's best not to use those. Better to use their arterial conduits. So we close these veins down. The best way to close these veins down, and it's all what I would say minimally invasive, because patients walk in and they walk out. There's really not any downtime. There's no cutting, no stitches. It's basically all done through a little catheter. So we just slide a little catheter in the vein of the leg and the lower part of the leg. Once we get that catheter in, then we decide, depending on what kind of treatment that they have, what we try to do is injure that vein enough where it closes. And there's multiple ways of injuring the vein. One is the thermal ablation. That's basically where we use heat. And that heat can be generated through laser, or it can be generated through radio frequency. And basically what we do is we just weld that vein closed, if you will. So we damage the inside lining of the vessel so much that the inflammatory response just shuts it down. Okay, so that's probably that's the most common thing that we do. And the next, which is kind of what we're doing more of now, because whenever we use those heat catheters, what you don't want is you don't want to burn anything other than the vein. So you've got to create this heat sink, if you will. So you have to, all along that vein, you have to inject something called tumescent anesthesia. And what that is, that's a combination of lidocaine and bicarb and saline that basically makes it so, number one, the patient doesn't feel it when we do it, but two, it creates a sink to basically dissipate some of the heat so we don't burn any of the surrounding tissues. It also, because it's pressurized in there, it'll actually pressurize and push the vein against our catheter so we get a better treatment. So you have to do that all up and down the vein whenever you're using one of those heat catheters. So one of the things that's kind of happened in the last couple of years is that rather than doing that, is there a way that we can not have to burn the vein but still close it, not have to have any downtime, and afterwards typically you have to wrap the leg so that it doesn't kind of ooze from all your stick sites. So the latest thing is now what's called Venous Seal. Venous Seal is basically super glue, it's cyanoacrylate. So we've been using super glue in the body since the 50s. We've been using it in brains, aneurysms, for AV malformations. We've been using it in the eyes. They've used it in cancer treatments for closing those. We've obviously used it in skin, and most of the people listening probably have used Dermabond. It's the same thing. And people at home use super glue, and it's basically the same thing. So it's just been modified a little bit. And we basically just go up to the top of the vessel. We super glue it closed, put a Band-Aid on the stick site, and the patient can immediately go and play tennis. No compression, no wrapping after that.
So you do that in combination with your ablation?
Yeah, so that is the ablation. So that is the ablation. So you don't have to do the thermal one anymore. Yeah. You can basically just use super glue. Now, there are patients that I wouldn't do it on. If people who have a lot of allergies, for instance, who are leaving a chemical in the body, people who have a phobia about, I don't want anything left behind, if you will, then, I'd probably do the thermal ablation. There's nothing left behind. As far as the how effective it is, it's really over 99% effective in closing these veins. So they work very well, and they work very well long term. We have 5-year data now out on Venous Seal and the long term. And it's never, like I say, it's been in the body. We've been putting it in the body since the 50s. There's been no documented case of any cancers or any bad effects of having long-term super glue in your body.
Seems like even better than the thermal ablation. I mean, because you still have some patients that recanalize after radiofrequency or even laser, within the first 2-3 years. But,
they do. And one of the beauty of it is that it actually, they've been shown in the animal model that the glue actually goes into some of the varicose veins that are attached to the great saphenous vein, which is the major vein that goes down the front of your leg. And so it actually treats a lot of your varicose veins as well. So that's one advantage of it as well. Just the thermal will just burn the vessel that it's in, but the glue actually seeps into some of these perforators that are leaking, and as well as some of the varicosities. And what they've shown in the WAVES trial, Kathy Gibson did this in London, that if she looked at, this was real live patients, and looked at what is the predictability of the need for ancillary treatment. So what she did is she did the Venous Seal, and she said there's about a 70% chance that I'm probably going to need to do phlebectomy on this patient. And then she waited 3 months, and then she saw how many of those patients she actually needed to do phlebectomy on. And it was down into the 20% range. So, and as well as sclerotherapy, which is injecting foam, which we'll get to in a minute. But so ancillary therapies were markedly reduced when you use the cyanoacrylate, the Venous Seal as well.
I guess the surgical vein stripping is gone. I mean,
Yeah, it really is. Especially for the great saphenous veins and what we call the truncal veins, which is the GSV runs right down the front part of your leg. It goes from your ankle to your groin, but you also have one on the back of your leg called the small saphenous vein, and it runs right up the back of your leg. And we treat that one as well. They used to strip those out, and they're deep veins and they're hard to get to. But the only ones that we're doing now is the ones that are very large and very visible on your skin, right up underneath the skin. Those large ones are still treated best with what we call microphlebectomy. And that's what we do. We do it right here in the office. So basically you just make a little stab in the skin. Sounds weird, but you just reach in there and you grab that vein, you pull it out through that hole. And it's kind of like digging for worms. It's a lot of fun, but but they all come out and patients are very happy because, they have these little sticks. They don't have any long incisions. There's no stitches, and it all heals up. And that big, ropey vein is gone and won't come back.
Venous lake completely out, with a
It doesn't sound right, does it?
What do you do with the little spider veins, telangiectasia? How do you approach those?
Yeah, so for these really tortuous, really curvy veins, you can't use a straight catheter like you would to deliver glue or deliver the heat. So for those, you have to use sclerotherapy. So it's basically a detergent that we use. Typically, it's polydocanol. And we use 1% polydocanol for the larger varicose veins, the ones you can't see but are there, but are too tortuous for you to do the ablation. We just inject this sclerotherapy, and it's just a foam. We have two ways of doing that. One way is what we call physician compounded foam, and basically what that is, and the reason why you want to foam it up is because it stays in the vessel longer, and the longer it's there, the more it damages the lining of that vein. So what we basically do is put in two syringes. It's just a clear liquid as it starts out, and you just go back and forth with the syringes, and it creates a foam. Now the bubble sizes of that foam are all different sizes, so it's not as effective as a stable bubble size. And so what they've created is actually a mousse. It comes in a can, and you can just put your syringe on this can, draw it out, and inject that. And that's a lot more, it works a lot better, but it's a lot more expensive. So we do that for failed physician compounded foam. So that's kind of the next step. Now for the small little veins, we typically don't even have to foam those up. We take a teeny little syringe with a needle on it, and we just inject it in those are right in the dermis. So those small spider veins, they'll go away. They'll turn, right when we do them, they'll go from that purple to a red, and then a red to a brown, and then a brown to gone. And so it'll be a progression over about a month before they completely go away. But you always want to treat the underlying cause. And you see these people who go get their spiders done every couple of months, but they've never had their reflux taken care of. And that's really the cause of this, is it's just that pressure's worked its way all the way to the skin.
So we talked a lot about the superficial vein, system. Let's dig a little deeper. Now let's go to the deep venous system. There's all kinds of, therapy that you do. Well, first of all, we know that, patients that have, varicosities and venous insufficiency will be probably 3 to 4 times as more prone to get DVTs or clot or thrombus, in the deep venous system. Can you explain to us a little bit, what happens? Why do they form a clot? And then what kind of treatment do we have for these patients?
Sure. So a lot of people who have, especially recurrent clots in their legs, have a structural issue. Now, it may just be that they sat on the plane a long time and their vessels got, kind of sedentary in the veins. It's very slow flow. So wonder they don't clot off more. But they can just get a clot. But recurrent clots, we always worry that there's some kind of compression. The most common compression up top is what we call May-Thurner syndrome. And basically what that is the aorta and the IVC, which is the aorta is the large vessel that comes out of your heart that runs down to your legs. The IVC is a large vein that runs up your body, going back to your heart from your legs. Well, as it splits, it forks, and it forks right about the level of the belly button. And so both of these vessels fork. But when they fork, they have to cross each other. So it's typically the left leg artery crossing over the right leg vein, okay, or vice versa. So you'll have the right leg artery crossing over the left leg vein. And when that happens, it actually compresses the vein against the spine. So when it compresses against the spine, then you have this kind of compression, almost pancaking of the vein. And when that happens, then blood can't get out of the leg. So blood goes down to the artery easy because those are thicker walled vessels. Then this very low pressure, very thin walled vein. And so with that, you have slower and slower and slower flow, and then eventually you can get a blood clot. The other thing that some people have is they have these large collaterals, what we call pelvic collaterals. So the body sees that obstruction, tries to find its way around it. And so you get all of these pelvic collaterals. So you get these blood vessels going around that blockage. And it can overwhelm the other side, so that these people can have actually bilateral symptoms, even though they only have a unilateral obstruction. And by treating that unilateral obstruction, it helps the bilateral symptoms. So we see people who have a lot of pelvic pain typically during their menstrual period, when they're kind of volume loaded to begin with. They start seeing abdominal or pelvic, large pelvic veins. And so whenever they get those, you always worry that the body's not trying to find its way around an obstruction. And so the way that we treat that is basically by opening it up. So we just place a stent in there, and the stent just gives it a little bit of scaffolding, a little bit more force to hold it open. When we do that, that allows the leg to empty.
Now, in the cardiac system, when we put a stent inside a vein graft, the rate of re-narrowing or restenosis is a little bit higher. What is the success rate? I guess that vein in the iliac and the pelvis is a lot larger, and you probably don't have too much problem with restenosis or re-narrowing of those veins.
Yeah, restenosis very low, actually. It's in the 5% or less range. And the reason is because, like you say, these veins are big. So to give you an idea, is we typically, our typical vein size stent that we put in is somewhere in the 14 to 18 millimeter range.
Wow.
So these are big stents. And so
big is probably 5.
Yeah, exactly.
It's like
they actually work very, very well. And there's a lot of really good technology coming out and really specifically designed toward vein stents. We've had these stents that have been around for eons that we put all over the place in biliary trees and everywhere else. But they were the only large self-expanding stents that we have. Now companies are really coming on board. We're understanding the venous anatomy a lot better. We're understanding these vessels a lot better. And so we're specifically designing, a lot of the companies specifically designing vein stents that will give you a little bit more scaffolding, that don't change the flow that much, that are a lot more easier to place, because sometimes they're a little bit difficult to place. So anyway, I do think that we're seeing a lot better technology going on with the deep venous system. So I'm really excited to see what kind of the next versions of stents. And we just now had 3 or 4 stents that have just come out, just hit the market, specific for the veins.
Wow, that's great. So let's talk about a patient who's had DVTs, and actually it was, it was all the way to, to the common femoral vein, as well as involving even some of the iliac veins. No PT involved, but you have this very, very large clot, and therefore a large clot burden. A lot of times you end up with this so-called post-thrombotic, syndrome, where the clot doesn't always completely resolve. What can you do to kind of help, with these patients? And acutely, is there a way to basically lyse the clot and try to help the clot dissolve? And what kind of time frame do you have after the DVT and so forth?
Yeah, so post-thrombotic systems, it's an absolute disaster when people get it because they're miserable. They have this huge leg that you can't walk on, you can't really do anything with. And what we're finding is that we have not been nearly as aggressive as we need to be. So if you have a clot in your deep femoral system, from your knee to your hip, your body can typically find ways around that. And the risk for a post-phlebitic syndrome in that situation is fairly low. So what we do is we just watch those. If within a month they're not better, then we go clean those out. But if they're better in a month and their legs aren't that big, just with typical standard anticoagulation therapy, oral anticoagulation, typically initially we start out with some IV heparin. But now the guidelines basically say you can start oral anticoagulation right off the bat with those patients. Now, if the clot extends more proximal to that, from the hip to into the abdomen, then standard therapy only works 18% of the time. to clear that clot. So it basically doesn't work. So we've got to be very aggressive, because those are the patients that are going to get the post-phlebitic syndrome. So basically what we have to do is we have to get that clot out. Now, the way that we get that clot out is you can go in, and there's different aspiration techniques where you can go in and just aspirate that. We have some that'll suck that clot out. We have some that even after that, you can lay a catheter that'll drip this TPA, which is medicine that dissolves the clot. We have specialized catheters called like ECOS catheter, which is a kind of an ultrasound vibration that kind of helps it penetrate the clot a lot deeper and work a little bit better. And we have these aspiration tools now. What we're using is the Inari Clot Retriever, and it's a very good device that actually allows you to go in and basically just pull it. It's almost like a nitinol or a metallic sock, if you will. And you basically put that sock above the clot, and then you just drag it through the clot, and it just catches all that clot in your sock. And so it's nice because you don't have to put patients on blood thinners for 24 hours. You basically just go in there and you can drag it. And you can typically do that anytime within the first several months. The clot organizes. You don't want to wait too long, because then the wall of the vessel gets damaged. So, but if you have somebody who has a persistent swelling or an iliac thrombus that's just not getting better, then you really need to be aggressive in getting that clot out.
Do you, in those circumstances, do you put a temporary IVC filter to protect against the clot, dislodging and get into the pulmonary artery? Or?
Yeah, so that used to be standard of care. And so you put in an IVC filter, then you go and you try to get it out. Now we don't. And several reasons. Number one is that it actually is a contraindication to using these clot retrievers, because you have to go through that area, and you have to start up high in the IVC and drag it all the way down. And so if they have one of those, you can't actually use that technique. And the reason why we've gotten away from it is because they basically found that it really didn't prevent clinically relevant PEs during the procedure. Now, do patients have small pulmonary emboli? Sure, they probably do. They get filtered out in the lungs, but clinical PE is so rare during the procedure that we don't do that anymore.
Right. So I think it's important to emphasize, you get clots like this, the blood thinners that we give, the NOAC or, like the Eliquis or Xarelto, really prevent other clots to form or prevents the clot from getting bigger. The body is, usually provides all the mechanism and does the work on its own, trying to lyse the clot as well as dissolve it, and it takes time. But when it's so big, so large, with so much effect on hemodynamics, then that's when you intervene and help the body, dissolve and remove some of that clot. I think you're right. Having an aggressive, strategy really prevents long-term, problems, because this is for life. Some of these patients were relatively young and, suffer from the rest of their life with venous insufficiency. This is what, I think we need to prevent.
Some of these patients who do have these clots, so, over time, even though their leg may get better and you have some non-occlusive thrombus in your deep system, those patients then develop venous insufficiency and start beginning the symptoms of venous insufficiency. And you can actually close down the superficial system in somebody who has non-occlusive DVT in their leg. And we do that. The reasons not to close the superficial system is if your deep system is completely occluded. But as long as there's flow through the deep system, most of the collaterals in the deep system go through deep vein collaterals. They really don't go through the superficial system anyway. Mm-hmm. So by closing down their superficial system, they can get clinically a lot better. The other patients we see get a lot better is as far as maybe not visually, but symptomatically, is patients who have lymphedema. So if you have somebody who has lymphedema or recurrent cellulitis and these really giant elephant, looking legs, then if they also have concomitant venous insufficiency, then by treating their venous insufficiency, you can actually help those patients symptomatically a lot. I don't promise their legs will ever look any better. That's more of a lymphatic issue, but their legs will actually feel better. they'll actually want to do more. And that's ultimately what you want in these patients, is to get them more mobilized.
Well, it looks like there's been a lot of advances in the last few years, for the treatment of chronic venous disease. Anything else coming up in the future, Bobby?
Yeah. So, I do think that as we start seeing, a lot more aggressive treatment of these things, we're really seeing the technology for treating DVT a lot better, get a lot better. They are, and I know that there are some in production. There's been some that have failed, and that is in patients who have deep vein reflux. And so if you have deep vein reflux, all the data shows, and they have valves in them too, that by treating the superficial system, that actually markedly improves your deep system. But you can treat the deep system, you can treat the superficial system, still have a lot of deep vein reflux. Those are a lot bigger vessels. And so, the question is, could you put in an artificial valve? There's some technology out there that, and they're in trials right now, actually, for small little vein transplants, if you will, and putting in valves. The issue with the valves is longevity. They have to be super, super thin, and they have to be competent. And that's a terrible combination, to be thin and competent and last a long time. So they've used some of the thinnest material that you can possibly come up with. And most of those, at least when they've used kind of the things that they've used for the heart valves, have not worked. And so now they're using very fragile little tissues like a placenta and things like that are very thin membranes. And so we'll see where that goes.
You think in the future you're going to get involved into this valve reconstruction?
I don't know about that. May have to leave that to surgeons. I don't know if I can get down to one of these things. Better leave me to just closing them. I'm better at that.
Well, whatever helps the patient, that's for sure.
Yeah.
Well, Dr. Robert Foster, great friend of mine, director of the Birmingham Heart Clinic Vein Center. Thank you very much for this podcast. Now we know a lot more about chronic venous disease, and we know a little more about what to do.
Great.
Appreciate it.
All right. Appreciate it.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.